Okay, I'm going to make a start, and if people join, then that's great. So, good evening, everybody. My name is Nicole Gordon, and I'm the CEO of Jnetics. Firstly, I just want to say that we're recording the session, so I hope everybody's okay with that. So welcome to the second lecture in our Diving into our Genetic Pool series. This series, which Jnetics has recently put on, aims to explore new technologies and topics relating to genetic testing, genetic disorders, assisted reproductive technologies, and their use and regulations. The main objective of this series is to introduce our community to important and valuable information that will allow for informed decisions to be made. At Jnetics, we firmly believe that knowledge is power, and our role is to be able to give access to this knowledge to everybody who should want it. So I'm just going to let a few more people in, excuse me. Jnetics exists for the sole purpose of educating, raising awareness, and testing for Jewish genetic disorders. Our main goal as an organization is to help individuals be empowered in their decisions when it comes to family planning. Tonight's lecture is called Genetic Testing, Regulations and Reality. We are extremely honoured to have with us on our panel tonight three special guests. Firstly, which is to the right of my screen, is Sarah Levine, Consultant Genetic Counsellor at the Centre for Reproductive and Genetic Health. Secondly, Julia Chain, who is the Chair of the Human Fertilisation and Embryology Authority. And thirdly, but by no means least, to the left is our very own Gila Vazmual, who is Genetics Outreach, Research and Development Manager, who together will discuss genetic testing, regulations, and the realities of genetic screening. Before each of the speakers, I will give you a little bit more background to them. But this evening, we're going to start with Gila Vazmual, who is responsible for assisting with the research, development, and delivery of genetics programs, developing the organisation's outreach and education activities through the UK, and ongoing genetic research projects. Gila has an extensive background and knowledge in human reproductive science and assisted reproductive technologies. Her academic background covered a BSc in biomedical science, an MSc in reproductive science and women's health, and a Master of Research in infertility in the English Orthodox Jewish population. Now I'm going to pass over to Gila, who is going to give you some further information on genetics. Over to you, Gila.
Thank you, Nicole, for that introduction, and thank you everyone for joining us tonight. I think as this session tonight is about genetic testing and its regulations and the reality of it all, it would be important and interesting to start with first understanding what genetics does and how we do genetic testing. So just as a very simple and quick summary to Jnetics as a charity, it was established in 2010 with the initial aim of just raising awareness and educating people about Jewish genetic disorders. And these were conditions that are more common in the Jewish people than in the wider general population. By no means, not meaning that they don't exist, but they were just more common in the Jewish people. In 2014, it swiftly changed to community screenings, where people used to be invited to synagogues, to community centers where they could come and get tested. And eventually this changed onto a 3-layered program where we now go into the 8 mainstream Jewish schools and we test sixth formers. There is a university program available that happens once every year where any student in the UK registered to a UK university can be screened. And lastly, it developed into a Jnetics clinic where anyone that had missed their opportunity to be screened before could be screened. And this would also mean couples, individuals that were dating, that were engaged, that were married, and anyone that had missed on being screened in the previous opportunities. So this is how Jnetics operates more or less. But when we look at Jewish genetic disorders, what are we talking about and why is it important for us to talk about these genetic diseases? So when we look at basic genetics, we know that we inherit 2 copies of every gene from our parents. So 1 copy from our mother, 1 copy from our father. And when we talk about genetic conditions, these are inherited. At the moment at Jnetics, we test for 47 recessive genetic conditions, and these were selected as they were the most severe ones and conditions that there's no cure for any of them. There is almost no to very little management to these conditions. And lastly, they are life-threatening and life-shortening. So these conditions, as I've mentioned, they are inherited in a recessive way. So that means that for a person to be born with any of these conditions, they must inherit 2 faulty copies of that gene. So for instance, there can be a carrier, and a carrier of any of these conditions would be a person that has only 1 faulty copy of that any given gene. So for example, some of the most common conditions that we know are Tay-Sachs, cystic fibrosis, and for anyone to be a carrier, they would have to just have 1 faulty copy of the Tay-Sachs gene, say for example. Now for tonight, it's important for us to focus on carrier couples. And what are carrier couples? Carrier couples are specific in the way of a couple, let's say, comes forward to Jnetics and wants to have a family. Before they do that, they come to us, they get tested, and they find out that they are carrying the same faulty gene. So say, for example, again, Tay-Sachs, just for simplicity, they're carrying a faulty gene for Tay-Sachs. So what happens to this couple? What are the next steps for them? How do they decide on going forward? We know that this given couple would have a 1 in 4 chance of having a child affected by Tay-Sachs. They themselves as carriers would never be affected by the specific disease at all, as they would never develop symptoms, would never go on to have any problems or ever be affected by the condition. The problem would only be their future children. So what happens to this couple? They have a 1 in 4 chance. Now, as I'm sure Sarah will talk about it in a bit later, what are the options for this couple such as these? Once they find out that they're carrying a genetic condition, that they might be affected, and they want to have healthy children, what are some of the options for them? So at this point, it's important for us to say that we work alongside the NHS, where we pay for a service where they offer genetic counseling, and as well as help couples make these decisions about what are the options, whether it's pre-implantation genetic testing, or choosing to go down a different path, but just having some support and help to make these decisions. So at this stage, we would offer genetic testing for anyone wanting to find out if they were a carrier of any of the recessive genetic conditions, and a place where they could come to find out more about Jewish genetic disorders. So this is just a very quick summary into Jnetics. And I think Nicole will now introduce Sarah, who'll talk more about the different options that couples have and what are their experiences once they get genetically tested.
Okay, thank you very much, Gila. Unless there's any burning questions, I'm actually going to hold questions till we've listened to all our speakers. So without further ado, I'm going to introduce Sarah Levine. Sarah is a consultant genetic counsellor at the Centre for Reproductive and Genetic Health, leading the pre-implementation genetic diagnosis, and has been there since 2017. Sarah started her career in cancer genetics and general genetic counselling at Guy's Hospital back in 1998, but has primarily worked in PGD and reproductive genetic counselling in recent years. Alongside her PGD work, Sarah ran the Tay-Sachs screening service at Guy's Hospital from 1999 to 2017. Sarah helped lead the way in the development of a broader panel of genetic tests for the Jewish population, and also contributed to the establishment of Jnetics. Sarah is the current chair of the UK Association of Genetic Nurses and Counsellors, representing the genetic counselling profession to the outside world. She sits in the medical advisory panel of the Jewish fertility charity Hannah, as well as being a member of Genetic Scientific and Medical Advisory Board. Over to you, Sarah.
Thank you. Thanks for that lovely introduction and for inviting me to speak this evening. So just to pick up where Gila has left off with the description of how the genetic screening then leads couples into choices about starting a family. So obviously, as Gila said, it's only what we're talking about is the carrier couples, the people who are both carriers of the same genetic disorder. And obviously now the Jnetics screening program does cover lots and lots of genes, as we heard 47, you will have many people who are carriers in a couple of different genes, and that's fine. That will not cause a couple to have any of those diseases that they individually carry. It's only those couples that they both carry the same gene, that's when they're at risk, that 1 in 4 risk that Gila mentioned. And so those are the carrier couples. We're talking about the ones with the matched same gene. And for them, in the past, traditionally, the main, or even one of the main options that would be available would be prenatal diagnosis. That would be to become pregnant naturally and then have a test early in the pregnancy, which would often be an invasive test, involve putting a needle through into the womb to take a sample. And that would allow a couple to find out during the pregnancy if the pregnancy was affected with the condition from 240 copies of the gene, and they could opt to have a termination of pregnancy. Obviously, that's not something that everybody's comfortable with. It's still a widely available option. But one of the more kind of growing popularity of options, although again, not suitable for everybody, is the area that I work in, which is pre-implantation genetic diagnosis. It's always been called PGD as the acronym for that. It's actually recently changed name. So just if people go reading up online and start to get confused by acronyms, it's now changed name to PGTM, which is pre-implantation genetic testing, and the M stands for monogenic, meaning a single gene. And that could be many different genes that we can test embryos for. So PGTM is basically when a couple who are at risk of having a child with a genetic condition will go through IVF treatment, even though they may well be fertile and not need to have IVF from that point of view, but purely so that we can create embryos in the laboratory out of their eggs and sperm, and then test those embryos for the genetic condition that they carry, that they're at risk of having a child with that disease. And that allows us to select an embryo which is unaffected by that genetic condition, and only use unaffected healthy embryos to put back into the womb to hopefully start a pregnancy. And so that's a way for couples to begin a pregnancy and not have to worry about the option of prenatal diagnosis and potentially termination of pregnancy. That makes it, for a lot of people, a more appealing option. There are other options entirely that we in the genetic counselling profession always do sort of mention to people, apart from prenatal diagnosis and PGTM. So there's the option of adopting children, not having children, or using egg or sperm donor to kind of replace a carrier partner, but those are all far less popular options. So my work these days is mainly in PGTM, because I do work in an IVF clinic where that's what we offer. And what I've been asked to tell you a little bit about this evening is just because the title of today's session is about regulation and reality of genetic testing. And I think Julie is going to talk more about the regulation aspect. So I'm going to tell you a bit about the reality. And I think that is important, because I think when you initially describe PGTM, it almost sounds quite magical, like it's this amazing idea that we can now create embryos in a lab. I mean, IVF's been around a long time, so we all know about that, but we can now do this testing and we can choose embryos and we can avoid a genetic disease, and that is a technology which is mind-blowing for everybody. And it really is, and when it works, it is life-changing. But I think where we have to think about reality is that it's a complicated process, it's an invasive process, and it's not always successful for every couple. It's not always suitable for every couple. And you know, I'm obviously a major advocate of this option, and want as many people as possible to be able to access it. But I also think it's very important that people are well prepared and realistic. And so I've been asked to kind of just tell you a little bit about what some of the complications, the challenges, the steps involved. And so just from a practical point of view, it's a lengthy process. IVF, you know, often is a lengthy process anyway, but there's an added set of steps when people are asking for PGTM, because we have to do the genetic testing side of things. And because what we're working with an embryo is a very tiny little thing. An embryo, we test the embryos when they're 5 days old in the lab, and at that point there's about 100 cells, and it's a microscopic ball of cells. And at that point, the amount of DNA that we can take 4 or 5 cells from the embryo for the test. That is an absolutely minuscule amount of material. Now, most people, when they're having a genetic test, with Jnetics or a kind of hospital setting, you're going to be having a blood test, or with the Jnetics test, a saliva test or a cheek swab type of test. Any of those tests give you masses of DNA. You can do lots of things with that. But when you've got an embryo and all you're getting is a few cells, you've got some real challenges from a technical point of view. So in order to be able to test embryos, our specialized PGT laboratory has to do preparation work with the DNA of the couple, and sometimes even with other family members of theirs, whether that's their parents or other members of their family. If they've already had a child who's affected with the disease, we'll use their child's DNA. And we're basically setting up a bespoke test, which will only be for the purpose of testing their embryos and only works for that couple, based on their DNA, and using a special kind of DNA fingerprinting method that gives us a sensitive enough test with this very tiny amount of DNA that we get. And so before somebody can even consider starting the IVF cycle, there has to first be a period of workup where we get the genetic test ready. And so there is a whole kind of set of steps that people have to go through before they can even begin the IVF. And they've got to get to us first. They've got to get through the referral process from the NHS and through to the IVF clinic. They've got to have fertility assessment to check that medically they're suitable for the treatment, go through the genetic counselling, then the genetic test workup. Only then can they start the IVF cycle itself. So that's, practically speaking, time consuming and onerous for people. And then in terms of the actual reality of what it's like to go through the treatment, obviously there's ups and downs for different people. And I often, when I talk to people beforehand, I sort of warn them of it being a bit of a roller coaster ride. And obviously for some people, there's better outcomes than others. But for example, even though these couples are usually not experiencing a fertility problem of their own, we still have to put them through the same treatment process as any other IVF cycle. So that means for the woman, they're going to have to go through a series of hormone treatments, which will allow us to stimulate the ovaries to make lots of eggs all in one go. And then a surgical procedure to collect the eggs from the ovaries after we've stimulated them. And so that in itself is sometimes for some women, not an easy experience, but also we don't know how many eggs we're going to get from each woman in their stimulation cycle until we're in it, until we've collected the eggs. And some people, get more than others. And there's a lot of there's a lot riding on that number of eggs, and a lot of pressure that women feel for that to work out well. Because one of the differences between having regular IVF and the type of IVF where we're testing the embryos and then choosing embryos is that naturally means we're going to have embryos that cannot be used because they've got the genetic condition in question, that have to be discarded. And so the fewer eggs or embryos you then start with, the less choice you've got. And possibly if you've only got a small number of embryos that go into the testing process, there is a risk of ending up, when you get the genetic results, just by bad luck, that they're all affected with the condition and all have to be discarded. And actually that whole cycle of treatment will come to an end without there even being the option of a pregnancy, because we haven't got a usable embryo to put back in the womb. And that does happen occasionally, especially if that kind of couple are on the older end of the age spectrum, or just do have some fertility challenges of their own, or they're just unlucky with the roll of the dice in terms of what the genetic results are for their embryos. So you just never know what's going to happen. And it is, a kind of fraught experience for people with lots of ups and downs. And sometimes they need more than one cycle before it even works out. And there are some people who go through this treatment for whom it never works. And that people have to be prepared for that beforehand, that we can't give them a guarantee that going through this treatment is going to give them a baby, because for some people it doesn't work. Now, saying that, I'm very lucky to work in a centre with pretty much the highest success rates in the land, and we do have lots of patients for whom our treatment is successful, and they have one or even more than one child as a result of having the IVF with the genetic testing, knowing that their child is now not affected by the genetic condition, and that is life-changing. So we see both the goods and the bad, but when it's when it's a difficult process, that is a tough road for people to go down. And obviously, you know, that will take a long time to even emerge. So people are going to be living with that stressful process for quite some time. So I think that that's just a really important reality if we're talking about reality today. And that's not to say that it's the only thing that's difficult in reality, because equally, if you become pregnant naturally in this situation and go through a prenatal test and are considering a termination of pregnancy, that is also, you know, of course, you know, emotional turmoil for a lot of people that go through that. So unfortunately, you know, for couples who have a genetic risk, they're often you know, stuck between a bit of a rock and a hard place, that any of the options are pretty difficult, and it's sort of making the best of the options available, really. At least I feel very lucky that we can offer people this option now, and in fact in many cases there is even NHS funding for the treatment, and people should know that as long as you meet a list of criteria, you are eligible for that, and you should be able to access the treatment through the NHS, and that in our centre we have an NHS contract to offer that. So I mean, there's lots and lots of detail around this, and I'm conscious obviously about how much time we've got, and I could give examples of different situations, but perhaps we might want to, I don't know if you want to move on, Nicole, to hear Julia's part about the regulation, and then we can talk about particular issues through the questions. Would that be?
Yes, I think that's probably the way forward. Listen, thank you, Sarah, for sharing us some of the realities of the process. It's very enlightening, and I'm sure we could listen to till evening. So let's move on to Julia, and then we'll come back and make sure there's plenty of time for questions at the end. So last but not least, welcome Julia Chain. Following over 30 years experience in legal and management roles in both private and industry, Julia was appointed in 2021 Chair of the Human Fertilisation and Embryology Authority. In her 3-year term, Julia will oversee the post-COVID work of the fertility sector for clinics and patients, and highlight where inequalities exist in access to treatment and outcomes. And she will focus on where the law needs to be updated. Julia is a very busy lady, and in addition to her role at the HFEA, she just recently stepped down after more than 8 years as Deputy Chair of Norwood, that I'm sure everybody's heard of. And she's currently Chair of SADE and Chair of the Human Dignity Trust. Julia has also held a number of positions as school governor and trustees of the Jewish Academic Trust. Now I'm going to pass over to Julia, who's going to talk to us about some of the regulations and more about the HFEA. Over to you, Julia.
Thank you. Well, thank you very much for asking me to speak, and it's a real pleasure to be here. I wanted to talk to you a little bit about the regulator, because actually none of what we've been talking about with regard to genetic screening or BGTM can really take place unless the license has been granted by the regulator. And I think that's very important, because it creates a framework for safe and ethical treatment. You know, this is not an easy area, and I think regulation in this field has been really successful, and I just wanted to talk to you a little bit about it. So the HFEA was set up by the HFE Act in 1990. So the Act is already a bit out of date. It's 30 years old. It's an arm's length body of the Department of Health and Social Care, which means we work, although we work on behalf of the government, we work independently. We have a non-executive board of about 14 and a staff of about 70 people. And we were really the first statutory body of our type in the whole world. So it is one of the probably few areas where the UK has actually set the gold standard for regulation. And to tell you briefly what we do, and then I'll come specifically to PGTM. So the main thing we do is we license and all clinics carrying out fertility treatment, IVF and other treatments. There's about 109 of them in the UK. Anybody carrying out treatments, storage centres, or any organisations carrying out research on gametes, which means sperm, eggs, or embryos. And all of those, any treatment or any research has to be licensed by us. right? It can't be carried out in the UK otherwise, and we operate across all 4 nations. That hasn't been devolved. So we license the clinics, we inspect clinics every 2 years. And in, extremis, although luckily we haven't had to do it for a very long time, we can take away licenses where clinics are not following best practice. And we have a code of practice which clinics have to follow to ensure that treatment is carried out not only safely and effectively, but also that patients who access fertility treatments, and that including treatments such as PGTM, have sufficient information to make really good informed choices. Because, as I'm sure many of you know, when you are accessing this sort of treatment, you are very vulnerable. It is there are a whole plethora of really difficult decisions that need to be made. And the important thing is to have the right information. And actually here, I'm sort of plugging this a little bit, which I was talking about actually at a conference yesterday. The HFEA website is actually a really good source of information. If you want to know more about PGTM, about IVF in generally, it has a choose a clinic function, and it's a very, very good first port of call for anyone thinking of either accessing fertility treatment or who've accessed fertility treatment and looking at, for example, things like PGTM. So we provide a huge amount of information to patients. We also, and this is relevant here, approve individual uses of genetic testing and mitochondrial donation. So what this means is, in the UK, unlike many other jurisdictions, it is illegal to select an embryo. So if you have fertility treatment, for example, and you produce a certain number of fertilized embryos, it is illegal to say, well, I'd like the boy or the girl or the one which I think is biggest or smallest or whichever. The only selection really is that doctors obviously looking at which is the best quality embryo to put back. But there are exceptions, and the key exception is to prevent a couple who might be carriers having a child with a serious monogenetic disease or genetic disease. And that is effectively what PGTM is about. It is ensuring that you are choosing the healthy embryo, the embryo that doesn't have the disease, to re-implant. But each time that happens, there has to be a special license from us, from the HFEA. Now, we have a register of more than, I think it's currently just over 600 conditions, including some very, very rare conditions. And the way it works is that if you wish to have PGTM, your clinician will apply, or clinic will apply to us for a license. If it is one of those 600 conditions, and that includes things like Tay-Sachs, cystic fibrosis, some of the more well-known conditions, and included some really rare conditions, then we will just automatically grant the license, because we know that is a licensable condition, if you like. If it is not a condition that we have come across before, i.e. no one's asked us to license it before, we have a committee that meets once a month of experts, and they will look at the condition. They will get as much expert help from clinical geneticists. We have 2 clinical geneticists on our board as well, and decide whether or not that condition is serious enough to be licensed. That process takes quite a short time, because we are aware that time is of the essence here, and that also for couples undergoing this treatment or looking to get a license, it's very, very stressful. And so we do work as hard as we possibly can to make sure that licenses, when we're granting licenses, we do it as quickly as possible. There is also a centre in Newcastle which is doing work on mitochondrial donation. That is a bit more technical. I won't go into it now, but it's where there is damage to the mitochondria, which are the little sort of batteries, if you like, in each cell that keep the cell chugging along. And when they are damaged, that can cause life-limiting, very serious diseases. And there is work being done there to see how that damaged mitochondria can be replaced with healthy mitochondria, if I can put it like that. So there is a lot of scientific innovation and research going on, and we keep a very close eye on regulating that to make sure that we, if you like, encourage scientific innovation, but always with an ethical framework to make sure that patients are kept safe, and above all, that patients have access to the right information. So along with genetic testing, I would also mention a couple of things because I think it's really important. Firstly, we also look, and anyone who's undergone fertility treatment will know that often patients are offered a whole range of what they call add-ons, which are additional treatments, which are purported, for example, to improve your chances of a pregnancy or perhaps reduce your chance of a miscarriage. We view those with some concern, and we have a sort of traffic light system which says that unless those add-ons have gone through some rigorous scientific testing, we're not going to approve them. They may not be dangerous. In fact, we're not saying they are dangerous, but what we're saying is, you know, particularly since over 2/3 of the clinics that we regulate are self-funding, so there is very limited NHS funding for fertility treatment. You know, we don't want women to be offered treatments which aren't shown to give them any benefit, but for which they probably have to pay a lot of extra money. So we do that. And finally, I think it's really important to talk about donors and donation. And last week, we published our report on sperm and egg and embryo donation. And I think this is really important. And I want to pick up on something that Sarah said, because people who are carriers of the genetic diseases who would like to apply to have PGTM in order to achieve a healthy pregnancy, that's fine if they can, you know, if they are suitable for PGTM and that treatment works for them. But often, or in some cases, PGTM is not suitable. It's not suitable for everyone, and not everyone can achieve a pregnancy using a healthy pregnancy using that technique. And some patients then turn and look to donors, either to egg donors, for example. And this is an area which is growing. Probably one in something like 170 live births in the UK is a child who is born through donation. That's about 1 in 6 of every couple who has IVF treatment will use donors, either egg or sperm, or usually egg or sperm donor. And it's a good alternative. The reason I'm just mentioning it, because it's quite interesting, is that the law changed in 2005, so that when a child who is donor conceived turns 18, they can have identifying information of their donor, so including last known address. And the first cohort of those children will turn 18 in late 2023 and will be able, if they so wish, to find out who their donors are and approach them with a view to getting in touch. Donors can't approach their children, but it can be the other way around. And that's an interesting thing, but it's also something to bear in mind. And I know I've done some work also with Hannah and so on. That is a bit of an issue in the Jewish community. There are a lot of studies which show that children who are donor conceived do much better if they have information about their donor parents and can contact them and so on. But it requires some thought. So this is not an easy field. The good thing about regulation, as I said, I think it provides a safe framework, an ethical framework also, for the medical profession to carry out what is really, cutting edge procedures, difficult procedures. We've come a long way, but they're not foolproof and they don't work for everybody. And scientists are constantly trying to improve the techniques and push the boundaries. And what we're saying as the regulator is, we support that. We will absolutely work with you. But, we need to make sure that what the treatments that are being provided are safe and effective, and that also women, patients have the best access to information at a time when they are really at their most vulnerable, so that they can make choices and decisions. And, sometimes these are very difficult choices and very difficult decisions. But as long as you have the information and the data, at least you can, make the best decision possible under the circumstances. And just to say that when you undergo things like PGT-M or any sort of fertility treatment, actually, it is mandatory for you to, as a patient, to be offered counselling. And I'm sure Sarah will agree with me that this is one of really the key planks of the regulation. And I'm not sure there's any other regulator where counselling is part of our legal framework, but it's really, really important. And we encourage all couples and people seeking fertility treatment and treatments such as PGT-M to take up counselling for that reason. So I think I'll stop there. There's lots more to say, but I think maybe now we've got some time for questions, so be happy to answer them. Thank you.
Thanks, Julia, and thanks to all of our speakers this evening. We have one question in the chat, so I'm going to start with that one. In addition to the regulatory issues so well presented by Julia, can we understand the Jewish religious and medical ethics position in this area? Who would, Gila, shall I put this one to you?
Yeah, I'm happy to start, and then perhaps Julia might have some knowledge to add on. I think when we look at these treatments, if we will, and technologies from a Jewish lens, the first thing that comes to mind is, the pikuach nefesh, so anything to save a life, particularly when we look at PGT-M. So there is a very positive light on using that technology to save someone's life and ensure that a couple can have a healthy child. We know that the primary and the first mitzvah given to human being was to be fruitful and multiply. And that has pushed, Jews in general, especially Orthodox Jews, to go forward and try everything they can to have children. So another thing, though, when we look at treatments is realizing that couples must go to their rabbis, and rabbis look at cases on a case-by-case matter. So, for example, Julia mentioned many different treatments. So whether it was a gamete donation and whether processes would be anonymous and then later on not anonymous. So there are many questions that arise when we look at things from a Jewish law lens. So for instance, who is the halachic mother when it comes to surrogacy, donated gametes? When we look at sperm donation, it is frowned upon. Some rabbis don't allow it. And don't think that it should be used. Obviously, surrogacy has a whole issue on its own. So there are lots of questions that come forward. On a general note, there is a positive light on using treatments to help couples have children, and especially PGT-M when it comes to helping couples having healthy children. I don't know, Julia, if you want to add anything.
Yeah, I mean, I obviously I wouldn't dream of sort of commenting on the sort of halachic aspects, but I think it's important to say firstly that Hana within the Orthodox community is a really good resource, because they exist really to advise couples about the halachic requirements and the halakhic landscape of IVF. And Dan Simon from the London Bet Din is an expert in this area. But I can tell you a few things, which is the general view, the general halakhic view, except in some extreme cases, which are usually disregarded, is that leniency is the main thing, and that most things are allowed in order to allow somebody to achieve a healthy pregnancy. And there is an organization called PUA in Israel, which I visited, where the director is the worldwide halakhic expert, Gideon Weitzman. He's actually a Brit, originally. And so even things like retrieving sperm samples, women ovulating before they've been to the mikveh, all sort of things which might create halakhic problems are dealt with. And I think it's important to say that the underlying view is that if it's possible, they will, they will be the most lenient of views, because achieving a healthy pregnancy is the most important thing that can happen. So I think that's quite positive.
I just jump in because obviously we've been talking about the Jewish position on those sorts of IVF technologies and all of these assisted techniques. But just to go back to the other thing that I was mentioning earlier about prenatal diagnosis in a naturally conceived pregnancy, which obviously you can imagine would have more halakhic issues because of termination of pregnancy. But I would say that none of these things are entirely cut and dried and black and white. And there are situations where even in the Orthodox world, there could be justification for termination of pregnancy, especially if the life of the mother is threatened. But what the threat to the life of the mother could be interpreted in quite different ways by quite different rabbis. Yeah. And where the kind of level of distress and psychological health of the mother could be very much at risk by the birth of a child that would have a very perhaps short lifespan or long-term disability, there would be rabbis who would support that. And there are also, of course, many people in our community who make the decisions based on their own personal ethics rather than the advice of a rabbi, and that's fine as well. And so we certainly have all range of positions, not just on the assisted reproductive side of it, but also on what happens in natural pregnancies where genetic conditions are diagnosed. And I think that's just important to recognise that as well.
Thanks, Sarah. Okay, I have another question. Do you think preconception screening should be compulsory prior to treatment? And anybody who would like to, Sarah, do you want to give a view on that?
So when you say preconception screening, do you mean like the Jnetics genetic screening for Jewish people? Yeah. Yes. So, I mean, as a genetic counsellor, I would never say that a test is compulsory, a genetic test. And the whole ethos of my profession is to provide people with information and support for them to make the decision that's right for them in a non-directive fashion. So I would never say it was compulsory. I certainly think that it's important. What should be compulsory is that people should be able to have the information and the access. Providing people with choice is what I think is the obligation on all of us, who understand these things and provide these things, to make sure that people have the ability to access a test like that if they want it. And I think that if a couple know about these sorts of tests and decide for their own reasons why they don't want to be tested, then of course that is absolutely right, that everyone should have that choice. But I think it's really incumbent on all of us who know about this to make sure that it's well understood and that people have access and choice.
If I could come in as well, I completely agree, Sarah. And I was actually today in a meeting with Leslie Reagan, who, as you know, is a new Women's Health Ambassador and running the government's Women's Health Initiative, because one of the things that we are both trying to influence is I spoke before about the importance of information and the regulator being, giving information to people about not only fertility treatments, but things like PGTM, genetic testing. We also feel very much that there should be much more information in schools for both girls and boys about fertility, about the issues of fertility, accessing treatments, the fact that regardless of however much you don't want this to happen, fertility does decline with age. So, biology is sort of against you. And also the importance of genetic testing, for example, before you get married, to just so that you know what the landscape is. In America, for example, it is actually, it's not compulsory, but it's extremely encouraged for all Jewish people getting married to have, for example, Tay-Sachs testing, and very unusual for couples not to have that. I certainly wouldn't think, and I agree with Sarah, that it's not up to us to say it should be mandated, but I think there should be a lot more information in schools, in sixth forms, about the consequences of not testing and the benefits of testing.
Thanks, Julia. Okay, we have another question. So it's something actually that came up before the session started, but we focused this evening very much on recessive disorders. But what about dominant disorders, of which BRCA is probably the one at the moment that's very hot off the press?
Yeah, so we're doing PGTM for recessive, dominant, X-linked and chromosomal genetic disorders. So there's all different kinds of genetic conditions that we can test embryos for. And of the dominant conditions, I would say at the moment that BRCA is probably one of the most frequent requested tests of embryos. We've been doing that at CRGH for many years. Actually, CRGH, where I work, was the clinic that first applied for and got the license from the HFEA for the BRCA gene. So it was pioneered at my clinic. But there are many dominant disorders, and we if the HFEA licenses the genetic test for that particular gene, then yes, that is something we are doing. We are testing embryos and discarding embryos on the basis of a disorder that may only affect that embryo much later in life. And that's an important thing to be frank with people about when you are discarding embryos, that if that means that you end up without having any embryos available for transfer, I think that is a place where there's perhaps more scope for regret for patients, that if that means that they end up not actually being able to have a child because they did discard all their embryos, and then they look back on it one day and see that treatments, prevention of cancer even becomes possible, that might they feel that they didn't do the right thing in discarding those embryos. So I think it's not straightforward for people to make that decision. I think it seems, at first glance that, and for any parent, you want to avoid your child being at risk of a health problem. That's natural for all of us as parents. But at the same time, sometimes these trade-offs are not cost neutral. I think that's really important to recognise. Yeah.
And I think it's also, when we license these conditions, we are very clear that they are life-limiting or, so serious that the quality of life is really prejudiced to a huge degree. They're not just possibilities of some disorder. And there is a very worrying trend now in America. It's still illegal, luckily, in the UK, for testing for, the possibility. So, this embryo has 30% more chance of getting cancer or diabetes or heart disease than that embryo. So let's choose the one without that possibility. You cannot do that in the UK. It's illegal, and I, for one, and certainly the regulator takes the view that we would never agree to that, because you're absolutely right. There is no suggestion at all that those embryos will, if they are born, will ever develop those diseases. And really, we are only looking at selecting out known conditions which are life-limiting and also create a huge amount of stress and pain to the baby that is born. It's very prescribed.
But I would say actually, Julia, just playing devil's advocate, that you know, as someone talking to patients with BRCA gene all the time about doing PGTM, that, you know, we have to acknowledge that the BRCA gene is not 100% guaranteed to cause cancer, and obviously amongst women, many of them will develop breast cancer. A large number may also develop ovarian cancer, but some women with the BRCA gene will never get cancer at all, and men with the BRCA gene will very rarely get cancer, although occasionally they will. And I mean, that's led to a really interesting debate in the genetics world currently, which is going on literally right now, about whether when we test embryos for BRCA, should we be also testing the sex of the embryo, which, by the way, normally is not legal in this country. Yeah. You can't test sex for embryos, but there is the exception for medical reasons where the impact of the disease is different for the sex, and that could be said about the BRCA gene. And there's a new piece of guidance that's been written from the constituent bodies of the British Society of Genetic Medicine that has just been published like literally a few weeks ago, saying that actually they recommend that embryos being tested for BRCA should be sexed, and that actually the male carrier embryos should be available to use, so that we're not discarding more embryos than necessary, and to give people the chance of you know, maximum chance of having a child who doesn't have a high risk of a cancer, because the men don't. But you know, this is all there are shades of grey here, and even
I completely
license
agree.
Conditions, you know, we have these questions.
Look, there are shades of grey, and we do license the BRCA gene, and we are aware of the guidance, and we're constantly, you know, reviewing what guidance we're giving, and we're constantly reviewing license conditions. I think BRCA is a little, I mean, I'm not a clinician, but BRCA is a little bit different because it's a much higher instance of cancer. I think what I'm talking about is these organizations that have sprung up in America where
polygenic disorders.
Polygenic disorders, which are, you know, small, not a very high percentage of sort of diabetes or heart disease, you know, which you know we have some treatment for. BRCA is in a different category, but I do agree, as we get more understanding about these conditions and where there's more research into them, there is definite shades of grey, and you know, it creates a lot of debate in our world about what we're going to license and what conditions we put on those licenses.
I think also, Sarah, to bear in mind that with the BRCA gene, although men have less chance of developing cancer, if they carry the BRCA gene, they have as much chance of passing it on to any children who are female or male.
But Nicole, actually, that raises another very interesting point, which is that the HFEA licensing process is intended for the creation of children who are themselves healthy, and it's not intended as a mechanism of eugenics. And if you said we want to do genetic testing of embryos in order to prevent the passing on of genes to the next generation where those are just carrier status, then you would have, then that is a whole other world of that we are not going down. And so, for example, if you've got a couple who are carriers of the recessive conditions we were talking about before, like Tay-Sachs and things, where we have embryos that are healthy carriers like the parents, one faulty gene and one normal gene, those embryos are absolutely usable. They are the same choice of embryo as a non-carrier embryo. It's only the embryos with two faulty genes that are going to have the disease that are discarded. Now, you could make the same case that if that's a carrier embryo, then if that embryo, when once grown up as an adult, has to have their partner tested in case they are a carrier couple, and we could rule that out by just not using carrier embryos. But that starts to lead that now we're going into eugenics. So, you know, if we would never make an argument in our practice, and I think the HFEA would be very upset if we tried to, of saying we want to screen something out because of further reproductive risk to the next generation. That's not what we're doing.
Okay, we have another. Can I ask about the age of testing? Gila, do you want to?
Yeah, sure.
Yes.
I just wonder if
Thank you very much. Very interesting talk so far. Thank you to the presenters. Yeah, my concern is that with the age of marriage getting higher, age of first pregnancy being 29.7 months or something now, if we're testing these kids in school, they're not going to be getting pregnant probably for 10 plus years. And the rate of change in recognizing the different genetic disorders changes. When I was young, it was only Tay-Sachs, and now we've got 47 things on the panel. So it's just a general observation. How will we cope with that? And how can we make it easier? Because obviously at the moment, it ideally would test them when they're engaged or about to conceive or whatever. But then that's incredibly costly for the couples involved, whereas obviously school and university genetics are providing the service for free.
Yeah, I mean, one thing I would say, and I will let Gila talk to this point, is that in the schools, yes, we are testing young, but in the schools, the education and the shifting the mindset of the community is probably as important as the physical test itself. And we do make it very, very clear that, you know, they are young and genomic medicine is advancing the whole time. And when they are getting closer to the stage of beginning to think about starting a family, that they should watch the space closely and potentially consider retesting. So Gil, I don't know if you want to add anything to that.
I think after being in schools for the last year and a few months and getting to meet with the students, when we meet the sixth formers, it's not just about getting them screened, but rather educating them. So as Julia and Sarah mentioned, there's a lot of information that is lacking just about them knowing what are these genetic conditions, why do they happen to the Jewish people, and why are we there to talk about it? It doesn't matter, you know, if they get screened or not, but what's important is that they know about it. And then later on in life, it might be more important. And we always say it. We say it to them, even as a joke. You're 16 years old now. You're not thinking about having a family, but in the future you might. And at the end of the day, this is also about your identity because it's your DNA. So it's as much as getting tested, but also about having that information so they can make their choice. We also notice at the Jnetics clinic, so another part of Jnetics is that we are getting couples that have been tested because our panel used to be of 9 genetic conditions, and only in last September of 2021 did it become a panel of 47 conditions. So we have had couples that were tested when they were in university and didn't pay for it, and have come forward with their partners and were retested. So we are seeing this. And for instance, in this university program this year, we saw students that wanted to be retested, but our recommendation was don't get retested now. Wait until you're ready to start a family and you find the right partner and you're ready to start, and then come and get tested again. And this is the important thing. They're aware about it. They know that it exists. They know that we are there to help, and they know that they can come to us whenever they're ready. And that's what's important for us at the moment. So just getting information and making sure they know we exist to help them.
And also by going into the schools, we're getting to sort of large numbers, and also we're getting to talk to the parents as well, because we run education sessions for the parents. So we feel like we're doing a job as an organization in educating sort of, you know, big chunks of the community. So
yeah.
Are there any more questions? No. Well, surprisingly, we have finished exactly on time, which is remarkable. A huge thank you to all of the speakers. It's been a hugely interesting and informative evening for everybody. We do realise that this is a very sensitive subject, and if anybody feels they would like to reach out to Jnetics or to Julie or to Sarah at any point, then please do come via Jnetics, and we will answer your questions, because sometimes this is not the forum to ask. And finally, just to say thank you to all of you who joined us this evening, and we will see you again soon. Please follow us closely, because we will be running further sessions in the series, and there'll be lots more interesting topics coming your way. So thank you, everybody.
Thank you.
Thank you.
Thanks for everyone.